This is the second part of the discussion of the treatment landscape for autism spectrum disorders. In the last segment, in the first part, we talked about behaviorist treatments and how those what those look like. Now we're going to move into developmental relationship-based treatments and what those look like. So here's where we are on the continuum of intervention approaches on the right-hand side of the line in the center. What you'll notice is that we have both developmental relationship-based programs that have some more shared control between adult and child, and then those that are really much more fully child-directed. I'm not going to talk about the distinction as much between the two of these in this segment, whereas in the behavioral treatment approaches segment I did. I talked about sort of the really adult-directed and then the more midline shared controlled ones. But in this segment we'll just talk about them as a kind of all of these as a whole. Again, these are some of the acronyms that you see on the previous slide. Let's start by talking about the main distinction between behavioral approaches and relationship-based approaches. So behavioral approaches say we're going to help a child become engaged in appropriate behavior. They're going to leave aside inappropriate behavior, and by doing so, they're going to learn about the world. They're going to be able to live and work and play and function in the world. So the philosophy is teach the child some skills, and then the child will develop relationships. On the relationship-based side of the continuum, the philosophy is that we help a child connect with other people and build relationships with them in a way that then promotes social and cognitive development and problem solving and flexible adaptation to the world. So in this way, in this kind of approach, we're saying help the child establish relationships first, and then the child will develop skills through having that relationship with other people. Vygotsky and Bruner are the mainstays here. This goes back to some of our discussion of basic theories of language acquisition back in language development class. I want to talk a little bit more here about the zone of proximal development. In a social interactionist theory, we can think about what kind of, if we're engaging the child in an activity or a joint task, then our role as the grown-up in a task that we know the child can't really do yet, our role is to really take over a lot of the responsibility for the task. So we organize the task, we provide a lot of high support scaffolding, we orchestrate the task so that the child doesn't really have to do a whole lot, and we're doing a whole bunch, right? We're doing a lot of the work. So that is represented here by that line on the very left-hand side. Notice that most of that line is the adult doing the task, and the little tiny triangle at the top is the child's role in the task. So just a little bit of role in the task. As the child gets more capable of handling the task, then the adult decreases his or her action within the task, right? We decrease our level of support or involvement, and we let the child have more responsibility in the task. And so the child is doing a lot more of the work, and we're there to support. And if we think about relating this to scaffolding, here we might be more on the low support scaffolds, so help a little rather than helping a lot. Then, as the child gets really good at the task, much more independent and competent at the task, notice that the line is almost fully in the child's role, and the adult just is kind of there helping out if need be. We're not doing as much in the task at this point. Most of the task is being accomplished by the child, him or herself. So I want you to think about relating this to scaffolding. In this case, when we're at this right-hand side, the line is at the right-hand side of this diagram, then we're probably providing raise the bar support here, because the child doesn't need high support, the child doesn't need low support. Now the child needs us to challenge him more and up the ante so that he has to do a little bit more and work harder. I also want to make it clear that when we plan joint tasks or activities for the child to engage in, we want to think about how hard the task is to begin with. And I'll relate this to your book treatment units. When you create treatment units for a child using books, let's say you've created a treatment unit for maybe 4-year-old children, and you've got a couple of kids on the spectrum that you're trying to use this book set with. And you sit down to start the first book, and a few pages in you realize, wow, this is way too hard for these kids. They are not ready for this. The task is way too hard. So what we do then is we provide a lot of high support, and we make them successful by scaffolding their success, but it doesn't always end up being the best learning tool for the child. And so we might need to adjust the activity and find a book that's a little bit easier. Now you might find the opposite is true. Maybe you've got your 2 4-year-olds and you've got your book set, and you introduce the first book and you realize, whoa, this is way too easy for these kids. They're not really learning anything because it's too easy, and I need to raise the bar to make it harder, or I need to find a book that creates a better opportunity for the children to learn. And so if we do the right kind of planning and we kind of pick the right activities that can maximize the child's ability, then we're in better shape. So we don't want to constantly be presenting tasks that are super hard and too hard for the child so that we have to scaffold a whole lot, and we don't want to always be presenting tasks that are too easy for the child. Instead, we want to kind of strive to be moving along in the middle of this diagram so that the child gets a lot of good learning opportunities with us. So social interactionist models are grounded in what's called a transactional model. And in this model, we see that people live within an environment. So there's the physical environment, there's the verbal environment, there's we live within an environment. That environment then includes the adult and the child, and we'll talk about a child on the spectrum and maybe their parent. When we teach the child to do something new, then the child does that thing, and the adult in the environment then responds differently because the adult realizes, wow, look what he just did. The adult is super excited about that and maybe responds differently to the child because of the child's new ability. Similarly, if we teach the adult in the environment to do something different, maybe to coach the child or to make the activity more accessible to the child, and the child then responds in a different way because now the task or the activity is achievable, then the child responds differently, and then the child then influences the adult. So do you see this as like a reciprocal, kind of cyclical relationship? It goes both ways. So if the child is not capable of doing something, having a really hard time and melting down, that's going to influence the adult to respond in certain ways. And so what we want to do is work on all the pieces here. We want to help the child improve skills. We want to help the adult learn how to interact with the child in ways that are facilitative. We want to set up the environment from the get-go so that the child can function better and that the adult can function better. But what we're emphasizing here is it's a transactional model. Everything influences everything else. It's not a simplistic model like behaviorists who say it's all stimulus response. So it's stimulus, response, reinforcement, shaping of behavior. That makes it sound a little too simplistic. And the developmental relationship-based treatments really acknowledge this reciprocal relationship among all of these different variables in a child's life. Here are some words that can help describe that transactional model in a different way. So read this and see how that maps onto what I just said. Let's talk about some of the treatment principles that developmental relationship-based treatments use. So first and foremost is child-centered strategies. So we try to achieve intensive engagement between child and adult, and it's very child-centered. We also try to use daily activities and routines. So we're not developing contrived activities that are really rigid or don't look like what kids need to be able to do every day. Instead, we use play, play, play. We use daily routines like bath time, bedtime routines, getting dressed in the morning, snack time, meal time, anything that the child could be involved in at home, like, help me with the laundry, let's pour you a glass of juice, something, anything. In school, we're going to use regular school routines. So we're going to capitalize on what is happening in the natural environment. Third, we'll look at across settings. We're going to provide treatment and try to have some alignment of treatment across settings. So we're going to use these approaches with parents at home, with teachers and paraprofessionals at school, and during speech-language services. So we're going to try to get a lot of alignment across all environments. Developmental relationship-based treatments also rely heavily on scaffolding, so we're trying to help the child participate in more sophisticated ways than they would be able to by themselves, and then we're going to gradually reduce that support. We're going to model language about what the child is interested in and attending to. We're not going to try to make the child stop the fun thing that they're doing in order to come do treatment activities that they don't think are fun. We're going to find things that they're interested in and that they're willing to do. We're also going to arrange the environment so that the child needs to communicate more. So we might use an approach like objects are visible but they're out of reach. So the child needs to do something or say something in order to be able to get what he or she wants. Some of my favorite resources, and this is not a comprehensive list, there's a bunch of them that I'll share with you throughout the semester, but you have your natural language acquisition textbook. In the past, I've also used Ann Densmore's book on helping children with autism become more social. I'll show you some of the Hannon products. The More Than Words is specifically aimed at children on the autism spectrum, but there are other Hannon programs that are also useful for them. We'll watch the Passport to Friendship video, and we'll watch a bunch of videos from the floor time model. There's a lot of good activities in the developmental, in the relationship development intervention, RDI. So these are some that you may find useful later on when you're in clinical practice. I also like these, the Rock series. These are very parent-friendly. They're very thin little books, and they kind of build. So early, you just teach them early social communication. Then you teach toy talk, how to build language through toy interaction, and then building pretend play. So you're moving up sequentially. So what developmental skills are targeted in developmental relationship-based programs? Well, it's a lot of targeting of joint attention, engagement, play, different kinds of gestures, speech sounds, echolalia, using echolalia and building on echolalia for communication purposes, first words and word combinations, and lots of work on pragmatic or social interaction. I would say that behaviorists try to address some of these as well. They don't necessarily do them in a developmentally sequential fashion, but they do try to work on some of these same things. The SLP in developmental relationship-based programs is not the primary or only provider, and so it requires that we really develop a lot of skills in coaching other people and helping them learn to implement these kinds of treatment strategies at home, at school, across environments. So we might provide treatment 2 times a week for a half hour to the child, but we are also giving other people a lot of coaching on how to do these treatments. Here are some video examples that, again, you can use to help you study for tests and make sure you understand the principles of developmental relationship-based treatments. What are some of the criticisms of social interactionist treatments? Well, one of the main ones is that the child may not get a sufficient number of opportunities to practice a target. And so we have to be very careful in planning for these kinds of treatments, because if we just go in and say, oh, let's pull some of these toys this child likes and put them in the therapy room, and we're just going to go in with no treatment plan, we're just going to waltz in and, figure it out as we go along. We're going to follow the child's lead. Well, one problem with that is if the child doesn't do much and doesn't provide us with much to build on, then we may not give them enough opportunities to do anything of substance, and that is a problem. So they might get 5, maybe 10 opportunities to do something during a half-hour session, when what they really need is 50 or 75 opportunities to do something of substance. And so we have to work hard on getting enough opportunities to practice targets. Treatment from in these approaches can be very loosely defined. So targets might be unclear. We might not have well-defined targets that we can address successfully. Again, it can seem very random and just, like we're going in without a plan. And that's not okay. That's not okay. The success of these programs depends very heavily on our skills as therapists, and so how talented we are at making play therapeutic affects the outcome of the treatment. It's also hard to teach others to implement treatment, and so we have to be really skillful at coaching other people. And when we're not really clicking with someone or feeling like we can get them, coach them successfully to do what we want, it can be very frustrating, and it can really negatively affect the benefits that the child receives from the treatment. The challenges for us in social interactionist treatments are that we have to give up control, we have to follow the child, and so we have to be ready to not always have a detailed lesson plan, and some of us really like to have detailed lesson plans. We like to know what we're doing. We like to prescribe the activities for the session, and that can be problematic. We have to go in with the willingness to have a plan, but then to kind of throw the plan out the window and follow the child's lead. We're not the ones holding the baby, so to speak. We're coaching others, and so we have to give up the control of always being the one, being able to be in the room and do the treatment ourselves, have the parent behind the glass, the one-way mirror, and taking a lot of data and saying, yes, we achieved our goal. We have to let go of that and let other people implement the treatment while we kind of coach them to get better and better at implementing it. There's no cookbook or manual, and so we have to be in the moment, we have to be creative, we have to be always kind of on our toes thinking about, okay, the child is doing this, what could I do with that? How could I build on that? It's a bottom-up approach. We really watch what the child is doing. We have to be very observant and creative. We have to have really good ability to model for parents and teachers and to coach them. We have to obviously be very diplomatic in how we coach without being offensive or making them feel like they don't know what they're doing. We have to be able to relate to them really well. And we have to be able to reflect on what's working and what's not working. And when something's not working, we have to be able to switch gears and try something different. And so it can be a little daunting. It can be a hard thing to do. These approaches are not entrepreneurial. They can't be packaged to sell as easily as some of the behaviorist treatments can. And so it's taken a while for us to get, so that slide I showed you with some of my favorite treatment resources, it's taken a while to get those into the public domain. And so I think for a while, the behaviorists were doing a really good job of packaging their treatments into a sellable product, and the developmental relationship-based treatment folks were not. And so it was hard, because it's hard to, it's not prescriptive, so you can't just, create a big 3-ring binder of this is what you do and this is exactly how you do it. So it's harder to create something that helps teach people how to do this treatment. And so we have fewer resources. That's getting better. There are a lot of trainings and things you can go to that will help. But you almost need to go to a training. You can't really just pull out the notebook and the binder and start from page 1 and implement something. You need a lot of training. And the last point here is that we need a lot more practitioners. We need a lot more people who are capable of implementing these kinds of treatments in order for children to be able and families to be able to access them. And right now there are a lot more professionals who are trained in behaviorism than there are professionals who are really good at these social interactionist treatments. To wrap up this entire segment on both behaviorist treatments and developmental relationship-based treatments, I want to emphasize that it's not either or. It's both and. So both types of treatments are really important for children on the autism spectrum. Children may need one type of treatment right now to best meet their needs, and then they might need the other treatment later on. They might need a mix of both treatments, so maybe they're in a verbal behavior classroom at school, but the SLP is going to use a social interactionist developmental relationship-based treatment to broaden that child's abilities and help the child generalize or address some social skills that maybe aren't targeted as well in their verbal behavior program. So what we want to do is consider what the child needs right now and continue to revisit the question of which treatment approach might be best for them at this time. I think what's really important is that we need to stop fighting about which approach is best. I think behaviorists will often be very entrenched in their behaviorist philosophy and unwilling and unable to entertain the idea that maybe the child needs a social interactionist approach. And the same is true with those of us who are social interactionists. We may really be entrenched in the idea that social interactionist treatments are the best thing since sliced bread, and those behaviorist approaches are horrible and they're damaging children, and right, so we get these kind of viewpoints and we get locked in. And there's been many times when I've been on IEP teams where I've seen a lot of discord and a lot of frustration in professionals working together, and it often comes from this bias that then we can't see what the other camp might have to offer. So we need to just stop doing that and have more respect for one another's views and ideas, and realize that a child might need behaviorism and a child might need developmental relationship-based treatments, and their needs may change over time. And so we need to be more cognizant of what does this child need, because remember, it's not about us, it's about the kid, it's about what the child needs most right now, and then we need to be willing to revisit that later on and say, well, maybe this treatment has worked really well, but maybe it's not exactly what the child needs right now. I hope that you've got a good sense for the kinds of treatments that are available for kids on the spectrum. SLPs will use a lot of these different approaches. I think we do a lot of mixing of behaviorism and social interactionist treatments, and we do a good job of that. We may need to be the voice at the table to help people work through the landscape of treatment approaches and to see the value, to help others on the team see the value of the different approaches, so that we can make good decisions as a team, instead of being railroaded by one treatment approach or the other kind of taking precedence.